Hello everybody, and welcome to Chapter 1 of your Anatomy 1 experience. Hopefully everybody's finding everything in Blackboard okay, and learning what's going on there. I'll try to keep posting new materials and new information as we go here, so hopefully everyone will be able to keep up with things. Let's briefly go through Chapter 1. As you will have seen in the Chapter 1 folder, you need to read a fair bit of Chapter 1. Most of it is read it, learn it, understand it, pretty straightforward stuff. But I do want to spend a couple minutes talking about some things that are a little bit more complicated perhaps to understand. The first one of those is the idea of complementarity of structure and function. Really, throughout your entire anatomy experience, I would like you to remember this concept. And what that is that the structure of some part of the body then determines what its function can be. Whatever its function needs to be then determines its structure. So the structure complements the function. The function complements the structure. They depend on each other to get the job done. An example the textbook uses is your teeth. Now, you would know that you have different kinds of teeth in your mouth, and they have different shapes. Some of them have sharp edges, and those are clearly designed for cutting things. Some of them have flat grinding surfaces, and those would be more for grinding and making into smaller pieces in the chewing process. So the shape of the tooth, in this case the structure of the tooth, complements or determines what its function can be. So just think about everything as you learn the anatomy of the body in terms of how does its shape or its structure determine or drive its function, and just appreciate that those two things go hand in hand with each other. Here on the screen we have an idea of what we call negative feedback. So the body needs to be able to maintain homeostasis, and you would have read about that when you were reading about the characteristics of living things. And so in this particular scenario, we're talking about temperature of the body. So the body needs to maintain a proper temperature. So we'll say 98.6 plus or minus a little bit would be what the body wants to do. And let's say the body gets a little bit cold. So the temperature goes below 98.6. Temperature receptors would detect that temperature change and send that information down here to the brain, the control center. The brain would then say that temperature is not what we want. It's too cold. To fix that, we need to go and do something. So the effectors in this case would be skeletal muscles, and that would cause you to start shivering. Now the underlying point of shivering is to create friction. Friction generates heat, so that would then warm the body up. So let's say the body did in fact warm up, and it would get back up to a balanced situation at that 98.6. Let's say the body temperature goes too high. So in this case, a receptor would detect that temperature, send it to the brain. The brain would say, in this case, things are too hot out here, let's cool off. It would go out to the effectors, in this case the sweat glands, and that would trigger you to start sweating. Really, sweating is taking hot water from inside the body and pumping it to the outside surface of the body, and that then takes heat out of the body and allows it to be released in the form of sweating and then the sweat evaporating. Now when you're hot and sweating, you don't necessarily feel like the sweating is doing a great deal of good for you, but take my word for it, it is very significantly assisting in temperature regulation. Once you get back down to that balanced temperature again, the sweating would turn off. So the point of negative feedback is when you achieve the desired outcome, the response turns off. So in the scenario where you were too cold, once you warm back up, shivering stops. When you were too hot, once you cool off to an appropriate level, the sweating stops. So the response is dependent upon the outcome, and if the outcome is achieved, response turns off. This ensures that you don't go too far. So the shivering doesn't continue past the point at which it needs to, and then you then get too hot, or the sweating doesn't continue past what it needs to and you become too cold. So this is really a system that achieves the desired outcome and then shuts off as long as it stays that way. Most of your body's homeostasis mechanisms work this way. Do only what you need to get where you need to be and stop. That makes sense. It's not likely to overdo it. There are a few situations where that doesn't necessarily work so well. So we would then have another option here that would be called positive feedback. In positive feedback, what happens is, let's say you cut your finger. When you cut your finger, you start to bleed, and a number of things are happening within the blood vessel and the blood there, but one thing that happens is you have a drop in blood pressure at that point. This seems to stimulate a process that calls for the arrival of platelets. Platelets are small cell particles that are really designed to block damage in blood vessels. So the blood vessel has been damaged, the platelet comes along and sticks to the area of damage to help seal it. So the idea is this is a relatively quickly forming plug that prevents additional blood loss. Now you want to have a little bit of blood loss with tissue damage because that helps to clean it out. And any potential pathogen that may have been introduced in, let's say, cutting your finger, hopefully would be washed out with the blood. But you don't want to bleed forever because only a certain amount of washing is useful. So when the platelets come along, they stick to that area where the damage occurred, and then it becomes somewhat of a domino effect. One platelet attaches and that calls for another. That platelet attaches and it calls for another. And you very quickly get that domino or snowball effect where one platelet sticking results in thousands and thousands of platelets being called for and then sticking to the area of damage as well. So in positive feedback, the outcome of your issue calls for more outcome, which calls for more outcome. So it builds and it builds into a bigger and bigger scenario. Sort of like what we're seeing right now with concerns about the virus. One person seems to have it, and immediately the entire community responds, then the entire state responds, then the entire country responds. So what was a very small stimulus at first results in a very, very significant and large-scale outcome. In this case, platelets continue to be attracted until there's nothing left to stick to. So all of the damaged areas of the blood vessel have been well covered in platelets. Then the bleeding will stop. So really, in real life, this takes maybe 2, 3, 4 minutes for an average cut finger to stop bleeding. So that tells you about how long it takes for this particular positive feedback mechanism to achieve its job. Then the signal or the call for platelets will slowly decline until there's no longer a call because there's nowhere to stick. The idea of a positive feedback mechanism really is to overdo it. With the negative feedback, what we saw was do it until you've got it done, then stop. Don't go too far. Positive feedback really goes farther than you need to. The idea there is, would you rather stop the bleeding more significantly than you need to, so build a bigger plug than you needed, or not build a big enough plug and keep bleeding? So in some cases, it's better to overdo it at least a little bit to ensure that you don't have problems that might arise from lack of getting it done all the way. So when in doubt, do more. Another really common example of positive feedback is in childbirth. Now, if a female has ever given birth to a child, you would know exactly what we're talking about here. But when contractions start, the point of the contraction is to push the baby out. So the uterus is contracting and trying to get this internal parasite out of the body and convert it to an external parasite. That might sound a little bit harsh up front, but if you've ever been pregnant, you would understand that definitely that baby is taking everything it needs from mama at the expense of mama. So technically speaking, babies are parasites. But in that process, the contraction occurs, and then at some point afterwards, another contraction occurs, and that was stimulated by the occurrence of the first contraction. The more contractions you have, the closer together they get, and the more powerful they become. So basically, again, one contraction calls for more, which calls for more, which calls for more, just like we saw with the platelets. That continues getting more and more aggressive until the baby actually comes out. At that point, uterine contractions actually continue for up to a month after the baby is out, but fairly quickly after the baby is out, it starts to recede and starts to be less common and less significant. So perhaps within a couple of days after the baby is out, you no longer feel the contractions, but they continue for perhaps a few weeks after. The object there is to make sure you don't get partway through expelling the baby and then stop. That obviously would be of no value. So make sure to get it out, get it all the way out, and after it's out, just make sure it doesn't come back in by continuing more contractions. Continued contractions will also help return the uterus to its prior size that it was before the baby was there. So it's more than just keep the baby from coming back in, but that's the original thought with overdo it to begin with. Obviously, we don't want every system in the body to work with an overdo it and then stop later concept, but in a few cases, like bleeding and giving birth to a child, it actually is very useful. Here we have Naked Boy. And Naked Boy has a number of different regional terms labeled. So the point here is, if we're trying to talk about something on some part of the body, there's a term for that part of the body. And rather than saying somewhere in the back, when we're talking about something on the shoulder region, we could say scapular, and that specifically refers to the shoulder. And that's more informative and more descriptive than saying somewhere in the upper back. If we wanted to talk about the face and something on the forehead, we could talk about the frontal region, and that would be much more informative or useful than saying somewhere high in the face. The point of these terms is so that you can describe something occurring in a particular part of the body very specifically so that other people can immediately know where exactly you're talking about. And that's very useful from a diagnostic perspective and from a descriptive perspective. And I don't know how to properly emphasize this, but until you've gone to a dermatologist and received a full head-to-toe examination, you cannot possibly appreciate how important all these terms are. In medical practice, every day, you will use these regional terms. So look at them, learn them, appreciate them. And you won't necessarily use every one every day, but you at least need to be familiar with them so you can very quickly figure out exactly what does this word mean. We also need to be able to describe where within that particular region are we. We can talk about the frontal region, but that still includes a fair bit of territory. So orientation and directional terms are very important. The first one on our list here is superior, and cranial is another word for that. I personally prefer superior, but again, cranial will work. Superior is talking about something that is more towards the head than the other thing in question. So we're always comparing two different things to each other. So if we say something is superior, it means it's closer to the head. The example here is the head is superior to the abdomen. Obviously, the head is closer to the head than the abdomen is. We could say the shoulders are superior to the hips. We could say the nose is superior to the mouth. So pick any two parts of the body that are up and down relative to each other, and the idea of superior might apply. Inferior means closer to the feet, so farther away from the head. The example here is the navel or the belly button is inferior to the chin. It's closer to the feet than the chin is. We could go back to our previous example with the head and the abdomen. We said the head is superior to the abdomen. The abdomen would be inferior to the head. Or the mouth would be inferior to the nose. It's closer to the feet. So the first one is always being compared to the second one. Anterior and posterior talks about to the front or to the back. And in this case, anterior could also be referred to as ventral. Posterior could also be referred to as dorsal. But do note the little star here in the description at the bottom. We're talking about humans. If you're talking about a four-legged animal, anterior and posterior, dorsal, ventral, they kind of change a little bit and start switching places with superior and inferior. So just take a look at that description and keep in mind what we're talking about is for two-legged, upright animals such as ourselves. I should also mention that all of these directional terminologies are always relative to anatomical position. So anatomical position is the position that we saw a naked boy in the previous image there. Feet pointed forwards, arms down to the sides, palms pointed out, thumbs pointed away from the body. Everything is relative to that position of the body. So anterior means towards the front of the body. Posterior means towards the back of the body. So our example here, the breastbone or the sternum is anterior to the spine. It is more towards the front of the body than is the spine. We could turn that around and say the spine is posterior to the sternum. It's more towards the back. The example for posterior here, the heart is posterior to the breastbone or the sternum, so it's behind, it's more to the back. That would mean the breastbone is anterior to the heart. We can look at medial and lateral. Medial means towards the middle of. Lateral means more towards the outside edge. So the heart is medial to the arm. It's more towards the middle than is the arm. That would mean the arms are lateral to the heart. We could talk about the sternum being medial to the ribs. The ribs would then be lateral to the sternum. Intermediate here is when we have three different things in comparison. All the others so far have only had two things being compared. The first compared to the second, but intermediate we'd have three. So the example is the collarbone is intermediate to the breastbone and the shoulder. That means it's in between the breastbone and the shoulder. So if we're talking about something in between two other things, intermediate becomes the appropriate term. Proximal and distal are terms that we will only use for the arms and the legs. Proximal means closer to the point of attachment for that limb, whether it's the arm or the leg. Distal means farther away from the point of attachment. So now we're back to only comparing two different things to each other. So for proximal, the elbow is proximal to the wrist. That means the elbow is closer to the point of attachment, this being the shoulder, than is the wrist. We could turn that around and say the wrist is distal to the elbow. It's farther away from the point of attachment. The example for distal is the knee is distal to the thigh. So the knee is farther away from the hip than is the thigh. We could turn that around and say the thigh is proximal to the knee. The toes would be distal to the ankles. The ankles would then be proximal to the toes. Superficial and deep are talking about closer to the surface of the body or deeper into the core of the body. So if we're talking about superficial, we can say the skin is superficial to the muscles. The muscles would be superficial to the bones. They're closer to the surface. If we turn that around, we could say the skin, or rather the muscles, are deep to the skin. The bones are deep to the muscles. We could say the skin is superficial to the ribs. The ribs are superficial to the lungs. The lungs would be deep to the ribs. The ribs would be deep to the skin. Hopefully all this is making sense for you, but practice. Pick any two parts of the body and figure out which of these sets of terms will apply. And with the exception of the intermediate, there's always a pair. It can be one or the other. So just pick two different parts and then figure out which set of terms applies and practice. The more you practice, the more comfortable you'll get with it, and after a while it will just become quite natural feeling. Here's an application of some of those terms. A CT scan through the superior abdomen. What does that mean? The abdominal region tells you this is the stomach region, where you expect to find stomach, large intestines, small intestines, liver, that sort of thing. Superior means it's through the upper part of that region of the body. So this tells us where we are. And even if they hadn't labeled this picture as left and right, remember it's always anatomical position, which means it's always the patient's perspective. So whatever the patient's right is, or the patient's left is the correct left and right here. And all the time this gets forgotten. So you perhaps have heard of people who, before having a knee surgery, will take permanent marker and write on their leg, "This is the good leg, don't cut here." And that might sound kind of silly, but it's really easy to forget, even for trained professionals, to forget that right and left is the patient's right and the patient's left. The caretaker looking on that person sees the patient's right as the left and the patient's left as the right, so you always have to remember to get that flipped in your head. It's always from the patient's perspective. So even if they hadn't labeled this picture right and left, we would be able to figure that out. We know the vertebrae always goes to the posterior part of the body, to the back. So we can say the patient is laying on their back for this image. We find the vertebrae here. It's at the bottom middle here, so that's the back. When we find liver over here to the side, we know liver's on the right side of the abdominal cavity. So we've said the back center is the vertebrae. Here's the liver. This has to be the right side. And when we find spleen over here, we know that spleen is typically on the left side of the abdomen. Then we have now determined left and right. Here's a picture of a heart. Now you don't really see the heart, but what you see are the arteries that supply the heart with blood. And part of the point of learning where things are and what they're supposed to look like is to know when it's not right when you see it. So even if they hadn't labeled this narrowing of the artery here, you would have been able to look at that and say, an artery shouldn't be this size here, the same size on the other side, but a very narrow opening in between. That doesn't make sense. So you would then know, just by knowing what it should look like, there's a problem here. So this would be a blocked coronary artery. And the traditional approach for a artery blockage of this magnitude, this is a significant blockage, not just a 20% blockage. This is more like a 90% blockage. Probably the solution for this is going to be a cardiac bypass procedure. Basically plugging in a bypass vessel that would go from the originating side around the blockage and plugging back in on the other side, and that would then restore blood flow. This is a very serious blockage because the heart supplied by that particular artery is a really big section of heart here. And if that part of the heart dies because of lack of blood supply, that's not a kind of heart attack that's an inconvenience but you get over it. That would be a most likely immediately fatal issue. So knowing what things are supposed to look like, knowing where they're supposed to be, then you can diagnose when there's a problem, when you see something perhaps out of place or not looking like it should. Here's another example of knowing what it's supposed to look like. In many scans, a brighter colored brain indicates a higher level of brain activity. In this particular kind of PET scan, it's not necessarily the case. So in a healthy person, what you would hope to see is more of a dull blue color, because here they're measuring a particular protein and its concentration. And in an Alzheimer's patient, you would see a brain on the left. So a lot of accumulation of that particular protein. And so in this particular scan, a brightly colored brain is not a healthy active brain. It's a brain that is shutting down. So this is as close as we can get to a definitive test for Alzheimer's. Otherwise, it's just a collection of symptoms that sound like Alzheimer's, and then do a brain scan to confirm that there are a lot of these proteins accumulating, and then the patient is diagnosed with Alzheimer's. So again, knowing what it's supposed to look like, seeing what it actually looks like, is quite useful. Let's say you go into the doctor and you're complaining of abdominal pain. The doctor will ask you to point to exactly where does it hurt. And what they're starting to consider in their mind is what you see here. Because in the abdominal pelvic cavity there are so many organs tightly compressed together, we really need to break it down into smaller sections. So we can break the abdominal pelvic cavity into quadrants, a right and left upper, a right and left lower quadrant. And so if you have problems or pain expressing in the left upper quadrant, your options are stomach, perhaps large intestines, perhaps small intestines, maybe a little bit of liver, but we're definitely not expecting to see a bladder problem expressing itself as pain in the left upper quadrant. Later on, we'll learn about referred pain and discover that there are some funny things that occur with pain and its expression, but for the most part, this idea helps us to start narrowing down what region are we in, what organs are there, and that helps to start working on a diagnosis of what could be the problem. If you have gallbladder problems, you would most likely experience some sort of issue in the right upper quadrant. So if the pain is there, the doctor starts thinking perhaps gallbladder is the issue. But that doesn't really break it down as specifically as we would like. So we can take those 4 quadrants, break it down into 9 regions. As you see here, the right and left hypochondriac, right and left lumbar, right and left iliac, and then epigastric, umbilical, and hypogastric down the middle. So if we wanted to be more specific and talk about a stomach problem, let's say perhaps a stomach ulcer, we might expect that problem to primarily express in the epigastric region. If you had a blockage in the small intestines, what region do you think it would most likely express in? Hopefully you're thinking umbilical. If you look at drawing B, the umbilical region is where most of the small intestines are located, although technically hypogastric could have some there as well. If we're talking about an appendix problem, we're probably looking at the right iliac region. So again, from a diagnostic perspective, this is quite useful in saying it's here, and in this region we have a smaller number of things present, and it helps to sort of narrow down what the problem is. Much of medical practice and diagnosis is eliminating possibilities. And once you eliminate all possibilities but one, then you have arrived at a diagnosis. So breaking the abdominal pelvic region into the 9 regions is very helpful to start eliminating possibilities. Hopefully all this made sense and was clear for you. If you have any questions, make sure to go to the discussion board for Unit 1 and post that question there. I'll try to keep track of that and get questions answered as quickly as possible. Make sure you're checking into the course materials and the announcement sections on a regular basis. As this week continues to unfold, there will be additional changes that occur there, and I'll try to keep you up to date on that. I'm hoping to be able to have the ability to have some live interactions where you can at least call in and talk to me live on Blackboard. I'm working on options to get that figured out. But if you keep up with the course materials and the announcements, you should be in good shape. So what you're going to find in the course materials right now is a link for Unit 1 online. So that's where all Unit 1 materials are going to be found for this experience. So you can ignore the folders in course materials that do not say online. Those are files that we normally would use in an in-person class. I'm building completely new files for this experience, hopefully in a more usable format. So what you'll find for every chapter is a reading assignment. Make sure you do that. And there will be reading quizzes on a regular basis show up that will hopefully verify that you've read the material and understood it. And if you didn't, you'll immediately know what you didn't understand about it. I'll also post videos like this for each chapter, and I'll probably put links for other videos that other people have made in those sections as well. So hopefully each unit chapter folder will be relatively all-inclusive for everything that you need to be doing for that particular section. Again, if you have questions, be sure to go into Blackboard, into the discussion center, and ask those questions, and I'll get answers to you. And hopefully this experience will work smoothly for us. It's certainly a new experiment for me, and I'm confident we'll get through it one way or the other. So If you have any questions, let me know. Have a wonderful day.